Uh, Hello, everyone. We are AFAN, the Association of Future African Neurosurgeons, and it's a pleasure to have you around. Today, we are going to have a presentation by Lorraine, who is a medical student from Botswana. But before we move to Lorraine, let me just introduce myself. I am Zolo Ivan. I'm a CTM medical student from the University of Buea in Cameroon. I'm the head of communication and operation at the Association of Future African Neurosurgeons. It's a pleasure to have you. So I'm going to give the floor directly to Lorraine and she can present herself and then start her presentation. You have the floor, Lorraine.
All right, thank you so much, Zolo. My name is Lorraine Sebopelo, and I'm a medical student here in the Faculty of Medicine in the University of Botswana. And today I will be giving a presentation on the relationship of spinal instrumentation to spinal fusion and patient outcome. All right. So the objectives of this presentation is actually to define spinal fusion and instrumentation, to understand the use of spinal instrumentation in lumbar procedures, also to find that link of spinal instrumentation to fusion and patient outcome, as well as to identify some of the controversies that may exist with spinal fusion. So this is how the presentation is laid out. The first thing we're going to address is the scope of spinal instrumentation, that it's for stabilizing the spine during healing, as well as the implants that will be used, the rigid and the non-rigid implants. And some of the examples are the classifications, actually, the segmental systems, interbody devices, and some prostheses. Also to define and identify those controversies when it comes to the efficacy and clinical outcome, and those vague guidelines that may exist when it comes to spinal fusion. So spinal fusion is actually just joining two vertebrae together to function as one unit. And spinal instrumentation is just using the implants to stabilize the spine by reducing movement between adjacent vertebrae, for example, during trauma. So this fusion is usually done by decotating adjacent bone surfaces and packing the gap between them, between these surfaces, with a bone graft material. So when I say decotation, I just mean the removal of the superficial parts of the cortical bone that covers the posterior elements of the vertebra, like the spinous process, the lamina, and articular facet. So you expose these vertebral cancellous bone, and this procedure is usually just done to accelerate the bone graft integration with its recipient. Well, when I talk about the bone graft, it's just the bone that is transplanted from a donor side to a recipient side to facilitate the fusion of the vertebra during lumbar surgeries. Or it could just be from the patient's hip bone, their own hip bone. So this instrumentation would act as a scaffold or support until this biological fusion takes place. So with the concept of spinal instrumentation, where exactly does this come from? So spinal instrumentation was established in the 1950s for treatment of spinal deformities due to polio virus that left children with spinal deformities. So the implants would allow for stabilization and bone fusion without interruption from moving adjacent vertebrae, and so you prevent non-union during the healing process. As I mentioned lately, there's classification of instrumentation, the rigid and the non-rigid implants. So the rigid implants just would include the segmental bodies and interbody devices, whereas the non-rigid implants just are those prostheses that usually allow for motion and is not usually used in combination with fusion. But this presentation will be more focused on rigid implants. Non-rigid implants are not used for fusion because with rigid implants, we want to make sure that the spine is fixed to allow for healing to take place. So these pictures just demonstrate or illustrate what I'm talking about when I say segmental plating. And the first picture, that's the segmental plating, and in the middle picture, it just shows the interbody devices that are used. So these first two pictures are the rigid implants. The last picture is the artificial disc, is an example of a non-rigid implant, the one that allows for mobility. So let's zoom in on the rigid spinal instrumentation. Segmental bodies, as I already mentioned, they are implants which are fixed onto the vertebrae with a pedicle, and then they're connected by rigid rods. And this would cause immobilization. Like I mentioned earlier, that we want to immobilize the spine to allow for healing to take place. So these segmental devices, the implants are fixed onto each individual vertebrae, and then they're connected in a rigid manner, or a rigid construct like a plate or a rod, like as illustrated in this picture. The first picture shows the subluxation of the vertebral body on top of another, and then the middle picture would just show how the screws are placed during lumbar procedures. As for interbody devices, these are rigid or elastic implants. They're also called interbody cages, or you can call them spinal cages. So it is designed as a cage to allow the bone graft to be placed inside the hollow cylinder to allow for spinal fusion to occur between the two vertebrae. The implants would allow spacing between vertebrae while healing takes place, and the plates can be used to stabilize the implant. So these interbody devices are rigid enough to maintain stability, but elastic enough for stress shielding. They're made of alloys like titanium alloys or the polyether ethyl ketone, the PEEK, or from biocompatible sources. For example, the intervertebral cage, which is inserted into a fracture, or a discectomy site for spinal alignment. The metallic alloys, such as the titanium alloys, they're usually favorable for their high strength and rigidity, and the fact that they function as good replacement for hard tissue, which is the bone tissue. And the advantages of the PEEK polymer is actually for its radiolucency, because maybe you want to see if the procedure went well, like in the last diagram here. If the patient comes a few months later and maybe they have back pain again, maybe you want to check if there's anything that went wrong, if the screws are still in place. So it's usually chosen for its radiolucency. For spinal fusion, the instrumented spinal fusion in the lumbar region is usually done whenever back pain is caused by abnormal motion between the lumbar vertebrae, or there's problems with the alignment of the spine. For example, conditions such as spondylolisthesis, which is just a condition where one of the vertebrae slips out of place on top of the vertebral body below it, the bone below it. Or they could also be used whenever there's painful motion segments. This can be discogenic pain, which just means that the pain is originating in an intervertebral disc, and that is produced by several factors. It could be a herniated disc or deterioration. Another thing, it could be just for symptom relief whenever there's back pain. And sometimes there could be that subluxation of the spinal segment. That's where we have that slight misalignment of the vertebrae. So some of the indications for spinal instrumentation, when can we actually say that this patient needs to undergo this procedure? So it's usually used when we want to treat unstable spines. Like in this case, the picture that I showed is of scoliosis, and it shows the before and after the procedure, how the procedure would realign the spine. Or it can also be used for degenerative spinal conditions with gross mechanical instability. So some degenerative spinal disorders can also include arthritic conditions, spondylosis, which is just an arthritic condition of the spine, or it could be arthritic conditions of the facet joints themselves, which shows in the last picture there, where there's that osteoarthritic spine, because it can lead to complications such as back pain due to impingement of nerves. And then last but not least, there's that we want to talk about the efficacy, of the spinal fusion. So when we talk about efficacy, we're talking about the performance of an intervention under ideal and controlled circumstances. So some procedures can actually be done without spinal instrumentation. However, it has been shown that procedures such as posterolateral fusion have been accompanied by segmental instrumentation. This is an opportunity for further exploration to compare non-instrumented and instrumented posterolateral fusion, whether spinal instrumentation can affect or is affecting clinical outcome in patients who essentially underwent compatible surgeries. So this brings me to my next point when I talk about controversies that may come up with this procedure. One may argue that there's an increased utilization of spinal instrumentation, which would reflect improved quality in care for an aging population. Or it can be said to be linked to potential financial motivations due to increased procedure utilization. How is the patient going to benefit? There are guidelines which have been published by various professional societies, and these guidelines, they remain vague and they are subject to a wide variety of interpretations. Studies show that spinal instrumentation in the lumbar spine does not enhance the rate of successful bony fusion, yet the ultimate goal of rigid instrumentation is to facilitate fusion. So this discrepancy raises questions as to the rationale of doing spinal instrumentation or instrumented fusion. Are we doing more harm than good? So in conclusion, I could just say that there are variations in surgical practice and techniques and instrumentation design. So these variations, they make it very difficult to make direct comparisons. There's also difficulty in making generalizations in studies due to differences in perspectives about pain, and there are those genetic variations among populations which are under study. So it makes it really difficult to make generalizations. Also, review studies have indicated that there is minimal connection between spinal instrumentation and clinical outcome. So with spinal instrumentation in the lumbar spine, I already mentioned that it is said to not exactly enhance the rate of successful bony fusion, but yet we say the ultimate goal of this rigid instrumentation is to actually facilitate fusion. So this inconsistency has risen a lot of questions. It raises a lot of questions as to the logic behind instrumentation, fusion, and spinal instrumentation. And lastly, in spinal surgeries, new technologies are actually leaving behind vital research on clinical efficacy. What do I mean by this? With new technologies that are coming up, it has been shown that there has been an increased use of instrumented spinal fusion occurring well before outcome data was available. So if this trend continues, if the trend of technical adaptation continues or technological adaptation continues without convincing efficacy data, there's no doubt that the cost related to spinal instrumentation will continue to escalate and exacerbate the strain on the healthcare system. But then again, on the other hand, an excessive regulation or focus on cost will definitely, most probably, prevent medical advances and actually compromise the creativity. So in the end, there must be a balance achieved between these opposing forces so that we know we are doing more good than harm and it's actually worth it. Thank you so much for your attention. I hope there will be questions. This is the end of my presentation.
All right, Lorraine, thank you so much. Thank you so much. So I don't have a question, sorry. So
Okay.
you're going to wrap it here, and okay, thank you for your time. Thank you for taking time to put all this together. So
all right. Thank you.
Alika.